Thank you. Thank you for the introduction. First of all, I would like to thank Florian, Isidro, and Aurelie for putting together the CIN community by organizing this series of CIN international lectures. In the first lecture, Martin just gave an excellent talk about pointing out the importance and technical challenges of reconstructing tumor karyotypes. And today I'm going to talk about how we can use the mutational processes causing chromosomal instability to inform treatment decisions. As Isidro just presented me, I'm Barbara. I'm a senior postdoc at the Computational Oncology Group at the CIN, and we are, in my group, we are interested in dissecting chromosomal instability to tackle those complex tumors in a more effective and rational manner. But why we are interested in chromosomal instability? So around 80% of all cancer patients present chromosomal instability. That is a hallmark of cancer linked to metastasis, poor prognosis, and therapeutic resistance. What I refer about chromosomal instability is this type of tumor genomes. And you can see here in this plot that there is like this genome with lots of copy number alterations around the across whole genome, and basically this is a super chaotic genome. And these plots are normally used for representing copy number alterations, where in the x-axis you can see the chromosomes order, and then in the y-axis there is the number of copies per genomic region. And I'm going to use these profiles to represent these chaotic genomes in my lecture. So a normal sample has 2 copies of each chromosome. So here in this plot, we will only see like a flat line at copy number equal to 2. So now you can realize about the complexity that those tumors actually have. So compared to stable genomes, tumors with chromosomal instability have these chaotic genomes with lots of copy number alterations. And the current approach of the precision medicine is based on the detection of just one alteration in a single gene or protein. This works quite well for stable genomes, but the huge complexity that the tumors with chromosomal instability have limits our ability to personalize treatment. And that is because in those tumors, normally we have driver alterations in several genes. And each one of these driver alterations is linked to different treatments with different targeted therapies. Therefore, treatment decision is a really difficult task for those tumors. And that's the reason why most of them are treated with cytotoxic chemotherapy. So the problem here is that we have the same treatment for all of these patients, and that is because we don't have a good biomarker to select the optimal treatment for each one of these patients. So having this clinical challenge in mind, in my group, we are interested on dissecting the mutational processes that drive a normal sample, a normal genome, to evolve into a tumor with these chaotic genomes, with lots of copy number alterations. And this is because if we understand the mechanisms driving this evolution, we can, in a way, limit the progression, the treatment resistance, the metastasis, and ultimately the death of those patients. So today, I'm going to present you 3 different stories around the same main goal. In the first part of my talk, I will present how we can infer the mutational processes driving chromosomal instability and how we can use these processes to understand the etiology behind those complex tumors. In the second part of my talk, I will present how we can use these mechanistic insights to predict treatment response. And in the last part of my talk, I will present you a recent work in which we use these mechanisms inside these mutational processes to forecast tumor evolution. So let's start with the first part. So in this first part of my talk, I will present you a project that we did in collaboration with Florian Markowitz's lab, in which we developed a new algorithm to dissect the mutational processes that cause chromosomal instability. And this algorithm, this method, is based on the concept of mutational signatures. So, as you might know, the genomic architecture of a tumor is the result of the different mutational processes that operate during tumorigenesis. Therefore, what we did was to look at patterns or genomic scars in these complex tumors, the same way that a detective looks for footprints at a crime scene. So what we did was to look for these patterns of footprints in the genomes with extreme levels of chromosomal instability, and we decomposed them into signatures. And then these signatures can be linked to deficiencies in specific pathways that actually can inform about what is the best drug or the best treatment to tackle those complex tumors. So the first thing that we did in this process was to try to understand which are the different copy number footprints or different genomic scars that are seen in these tumors with high levels of chromosomal instability. And for that, we look at the literature about which are the different copy number patterns that are normally seen in these complex genomes. And what we did was to look for features that explain the differences between these copy number patterns. For example, we started with a simple feature about segment size. So, for example, amplifications are normally defined by source segments. They are source segments that have a lot of copies, but in terms of segment size, they are short. Or if you compare that with chromosome segregation, those are normally long because they are the same size that a chromosome, the whole chromosome, or an arm of this chromosome. So we have a feature that can distinguish between the different copy number patterns. Then we have also another feature that is the change point. What is telling this feature is about the number of copies that change compared to the neighborhood segment. And in the case of amplification, we have high differences because they are huge amplifications. So there are copy number changes higher than 4 in this case. But in the case of chromosome segregation, we gain all those of 1 copy. So this change point is just 1 copy. So we can still differentiate between the different patterns. And we did that for the different copy number features. We also have another feature, 2 different features that integrate the information about if these segments are clustered together in the genome or not. And then we have a 5th feature that is telling us the length of oscillating changes. And these oscillating changes are typically seen in tumors with tandem duplication phenotype. So we have these 5 features. We have this information that explain the copy number patterns seen in the literature. And then we use these features to extract the information from the TCGA, that is the cohort that we use as a reference. So we extracted these 5 fundamental features in the TCGA. And the first thing that we did was to explore the distributions of those features in the cohort. So we see what is the distributions in terms of segment size and so on for the 5 features. And then these distributions were used to define categories for each one of these features. And for that, we use mixturing modeling. So we apply a mixturing modeling for defining the different components or categories per feature. So for example, in the case of segment size, we see 22 different categories, 22 different Gaussian distributions in this TCGA, and we use that to define 22 categories per segment size. So we did the same for change point. In this case, we have 10 different categories. For the copy number alterations for 10 megabases, That is another feature that is informing us about these clustering segments. And we have three features, three components, sorry, and then 5 for the copy number alterations per arm level of the chromosome, and 3 categories explaining the length of these oscillating changes. So this process was done to define a feature encoding. So how these copy number patterns are explained in the TTG. So when we have this feature encoding, what we did was to use that to extract signatures, to extract the information, the copy number patterns that are in the genome. What we did was to compute the probability for each one of these copy number alterations to belong to each one of the categories that we have already defined. So just let me explain that with this example. This is just like a toy copy number profile. We did that for each one of the samples. In this case, we have 3 copy number alterations because we don't use those segments that are copy number equal to 2 because they are normal and we ignore them. So what we did was to take these copy number alterations and compute the probability to belong to each one of the categories that we defined, in this case for the segment. So for example, this short segment has a high probability to belong to categories that are defining short segment sizes, and a low probability for those categories that are defining long segments. So this process was done for all the copy number alterations, and then we sum up to have a vector that is a sum of posterior vector for each one of the samples. And we did that for the 5 features that I have already explained. So once we did that for all the features and for all the samples, we constructed a summary of input matrix. That is a sum of posterior matrix that actually have the columns are the 43 components, so the 43 categories of these 5 features, and the rows are the samples included in the TCGA. And then for extracting these signatures, for deriving these copy number signatures, we use non-matrix factorization. That is a method that is normally used in the field of mutational signatures. So this method, what is done is to deconstruct the input matrix, this sum of posterior matrix that is capturing all the genomic scars seen in the genomes of the TCGA into 2 different matrices. One is the definition matrix that actually defines the different signatures that are extracted from this cohort, from the TCGA. And in this case, we extracted 17 signatures, and these signatures are defined in the feature encoding that we have defined. And then we have an activity matrix that is giving us the level of activities of these different signatures in the different samples that are included in our cohort. So this process of non-matrix factorization actually was explaining 17 patterns of copy number alteration, 17 signatures of chromosomal instability. And the next step was to know what are the biology behind those signatures. So we wanted to know which are the pathways that are defective and are causing these genomic alterations, these patterns of copy number alterations. And for that, what we did was to integrate orthogonal data from different data sources. So we integrated genomic features, several clinical alterations, response to different treatments, and so on. So we integrated a lot of data to be able to link those signatures to deficiency or to specific mutational process. So here, there is just like a table that summarizes our compendium of signatures of chromosomal instability. And here in each row, you can see the 17 signatures that are included in our compendium. And they are ordered according to the prevalence at pan-cancer level. And here you can also see the prevalence of those signatures across the different tumor types that are included in the TCGA. Then what we did was to link these signatures to a putative cause. And what we create was a confidence rate to rate what is the confidence, so what is the levels of orthogonal data that are supporting this link between the putative cause and the signature that we extracted. So in this case, for example, for signature 1, we know that this signature is linked to misaggregation errors. We have high confidence because all the data that we integrated was in line with this association. And actually, the pattern of change that is defining the signature is whole changes of whole chromosome or arm level chromosome. That is actually what is causing chromosome misaggregation errors. So we have signatures that have super high confidence, and then we have others that we don't know what is the etiology behind them. And we need further exploration to link those patterns of copy number alterations to any deficiencies in a specific path. So actually, this table is representing mutational processes that are linked to our signatures. And we see the typical ones defined in the literature as we have signatures that are linked to mutative errors. We have three signatures that are linked to impair homologous recombination. We also have a signature linked to impair non-homologous enjoining, and several signatures linked to replication stress. And in fact, replication stress is one of the major causes of copy number alterations. And we see replication stress linked to different of our signatures. And this is like just a summary of our compendium of copy number signatures, and which are the different pathways that are linked to them. So these signatures represent different types of chromosomal instability. So just like a summary of the first part of my talk, I just present you a compendium of signatures that can identify and quantify the different mutational processes causing chromosomal instability in those complex tumors. And these signatures actually can be used to identify tumor phenotypes. So, well, I already told you that we have these compendium signatures, and given that these signatures can be easily measured in tumor genomes, then our next step was to assess the utility of those signatures in the clinical setting. So the idea is that we have these signatures that are like genomic biomarkers. They are telling us what are the genomic scars that are in these tumors. And then these signatures actually are linked to specific mutational processes. So we know which are the different types of chromosomal instability that have been operating during the lifetime of those tumors. So then this information actually can be used to predict response to different treatments. And we have already demonstrated that those signatures are linked to can predict response to cytotoxic chemotherapies and also to targeted therapies. And we also have used these signatures to discover novel drug targets. And today, I'm just going to focus on the work that we have done to demonstrate that our signatures can predict response to 3 different cytotoxic chemotherapies: platins, taxanes, and anthracyclines. So the aim of this work was to use our signatures to predict or to classify patients as predicted resistant or sensitive to these 3 cytotoxic chemotherapies. And that is because if we can, in a way, identify those patients that are resistant, we can avoid the cytotoxic effects that have those chemotherapies. And those patients are not going to have any benefit for being treated with those chemotherapies. So that was the aim. And the first thing that we did was to create a clinical classifier for platinum-based chemotherapy. And for that, we use two of our signatures, two of these 17 signatures included in our compendium. And those signatures are linked to impaired homologous recombination. And actually, tumors with impaired homologous recombination, so those tumors are normally sensitive to platinum-based chemotherapy. And for that reason, we use this as a hypothesis, as a starting point to define these clinical classifiers. But the point is that even tumors with BRCA mutants, there are some of them that respond quite well to platinum-based chemotherapy. However, there are others that do not respond at all. So our idea was that if we can use these two signatures or these signatures of impaired homologous recombination to identify those patients that are going to be resistant, we can in a way avoid these toxic effects. And for that, what we used as a proxy was the ovarian tumors and the esophageal cancers, because they are normally treated as a first line with platinum-based chemotherapy. That's the standard of care of those tumors. And we can use overall survival to see if those signatures have any predictive capacity. And actually, what we see is that the activity levels of CX3 were linked to sensitivity. So those tumors that have high levels of CX3 normally have longer survival times. However, CX2, the activity levels of CX2 were not predicted at all. So after seeing these results, we just came up with a super logic classifier. That is that if CX2 activity levels are higher than CX3, then those patients are going to be resistant. So we tested this hypothesis by comparing overall survival in different ovarian and esophageal cohorts. And actually, we see that those that are classified as resistant had a shorter survival. So then the next step was to create a clinical classifier for taxons. And for that, we use another signature, CX5, that is also related to impaired homologous recombination, but those tumors also have levels of replication stress. And actually, for example, in triple negative breast cancer that have homologous recombination deficiency, it seems that they actually respond to taxons. And for creating this classifier and to demonstrate the ability of CX5 to classify patients as resistant or sensitive to taxons, we use in vitro data coming from the deep lab. So what we did was to correlate the activity levels of CX5 with paclitaxel response. And we use also this cohort to optimize the threshold for classifying patients as resistant to taxons. And then the last classifier was a classifier to predict resistance to anthracyclines. And in this case, we use three different signatures, CX8, CX9, and CX13, that are linked to amplification generating processes. So patients that have these high levels of these signatures actually have a lot of amplifications, focal amplifications. So doxorubicin is a chemotherapy that causes DNA damage, and normally this DNA damage results in micronuclei formation. So our hypothesis was that if those patients that have high levels of CX8, CX9, and CX15, they have these focal amplifications, are already being in contact with having the genome in their cells, micronuclei, they are going to tolerate better the damage that is caused by doxorubicin. So because they are already having amplifications, they are more tolerant to this damage caused by doxorubicin. And we tested that hypothesis using in vitro data. This in vitro data is coming from the James Frankel lab. So they have cell lines of ovarian cancers, also spheroids and organoids that are coming from ovarian patients. And we see that those patients that have higher levels of CH2, CH9, and CH13 actually respond better. So we optimize a threshold to detect those patients that are going to resist to these doxorubicin 3. So we have these clinical classifiers, and then the next step was actually assess those biomarkers. But the problem here is that, of course, nobody wants to run a clinical trial using biomarkers for predicting response to chemotherapy. But we can use retrospective data. So that is what we did actually. We use retrospective data to mimic clinical trials, and we assess our biomarkers using actually real world data. So the first thing that we did was to mimic a phase 2 clinical trial to test the predictive / prognostic capacity of our biomarkers. And what we did was to take a tumor-specific cohort. We derived the copy number profiles. We used our signature-based classifiers to stratify those patients as resistant or sensitive to chemotherapy, to the chemotherapy that we are interested on, and then we compare the time to treatment failure between the resistant and the sensitive patients. And we started this process with an ovarian cohort, the OVO4. This cohort is part of a clinical study run by James Brenton. And we actually see that the survival time, the time to treatment failure was shorter for those patients that we predicted as resistant. We validated that using the TCGA ovarian cohort. And then what we did actually was to expand these classifiers to another cohort to have to test if these classifiers can be used as a lung cancer level. So we assessed in breast, head and neck, and cervical cancers from the TCGA, and we also tested the predictive capacity in metastatic prostate cohort coming from the Harvard Medical Foundation data. So we have these tests. Actually, it seems that those classifiers are actually working quite well, but I mean, the best is to have a phase 3 clinical trial. So we did that. We mimic, the last thing that we did was to mimic a phase 3 clinical trial to predict the capacity or the predictive capacity of our biomarkers. And we did exactly the same process. Once we have the copy number profiles of the different tumors, we stratify them as resistant and sensitive, and then we compare the time to treatment failure. In this case, for those patients that are treated with the chemotherapy that we are interested on, with the standard of care for both resistant and sensitive patients. And the first thing that we tested is that if those patients that are predicted as resistant, actually the sustained treatment failure was shorter for those that are treated with the chemotherapy that we are interested on, because they are resistant in a way. And we actually observed that those patients that are predicted as resistant have a shorter survival time relative to the standard of care treatment. And then what we see is that those that are predicted sensitive actually have a similar time to treatment failure than the standard of care. That actually this is confirming that our biomarker is actually identifying those patients that are actually resistant to the treatment. So just to sum up this second part of my talk, these signatures, I show you that they can be used to predict treatment response. And actually, specifically, I show you that those signatures can be used as biomarkers for tailored administration of chemotherapy. So I already told you that we have this compendium of signatures that can be used to understand the biology behind those complex tumors. We can use this biology, these mechanisms insights to predict treatment response. And now the next thing that we thought is that maybe if we can dissect those mutational processes that are active in a tumor and are driving the accumulation of more and more copy number alterations, if we use this information, we can in a way forecast tumor evolution. But of course, forecasting tumor evolution is a really big challenge. And we started by constructing a framework to forecast oncogene amplifications. So this framework is actually based on classic evolution analysis. So to fix a mutation in a population, you need that this mutation occurs. So you need the process that is causing this mutation, that the mutation is acquired in a way, and then that this mutation confers a selective advantage. So this clone or the cell that harbor this mutation actually expand in the population, and we can detect that at both sequencing level. If we move that to the oncogene amplification field, we need that an amplification generating process is active in a sample, that this amplification generating process causes a mutation, an amplification, sorry, that confers a fitness advantage to the cell, and then this clone harboring the amplification is expanded in the population. So we integrated that in our framework, but we also introduced a different term in the framework that is actually modeling the topology of the genome. And that is because we need, for the acquisition of an oncogene amplification, we need that this amplification generating process hits the specific genomic region where the oncogene is located. Because if not, this amplification is not going to be acquired never. So with all these forces that are important or impact on the acquisition of oncogene amplification, we construct a forecasting framework. This framework is using a copy number profile as an input file. And this input, actually, we only use genomic data because most of our clinical collaborators only have genomic data coming from the clinic, and that's our main goal, to apply this framework into the clinical setting. And this copy number profile can be derived from whole genome sequencing, shallow whole genome sequencing, exomes, and also targeted panels. And then this copy number profile, we introduce that in the framework, and the output is the forecast of the oncogene amplification. So the sample, this patient, is going to be classified as high risk or low risk of acquiring an oncogene amplification. And this framework has two different steps. The first step is when we compute an amplification score. And this score is giving us the risk of acquiring the amplification that we are interested on. And for that, we integrated this classical evolutionary theory. So the first thing is to compute the signature activities in a tumor. And for that, we use the signatures, the same compendium of signatures that I explained you in the first part of my talk. We extracted that from the input profile, and then we also integrated in this process two different terms that are modeling the other two parts of this classical evolution. So one of the terms is the topological constraints, and for that we compute the signatures that are actually underpinning an oncogene amplification. And we learned that from 271 oncogenes from tumors that are coming from the TCGA, the PICOR, and the high-risk foundation. And we did that for each one of the tumor types that are included in those cohorts. And basically, what we are having here is the signatures that are enriched in those oncogene amplifications per tumor type. We were able to do that, to compute this signature enrichment, because we modify our compendium of signatures, the features that are defining these signatures, to be able to map each one of the signature to the genomic region where the gene is located. And then we also have a different term that is capturing the fitness effect of acquiring this oncogene amplification per tumor type. And for that, we use GSTIC, that is a software that normally is used, that is used for computing positive selections at copy number level. Once we have this amplification risk score, then we move to the second part of the framework that actually binarize these scores. And this is because in the clinic, we need a classification of the samples, because the clinicians want a binary classification of those patients to know what is the management that they have to do for each one of the patients that are included in the frame. And for that, we train a threshold, an optimal threshold in a reference cohort. We have a reference score for the different clinical use cases that we are applying this framework. And with that, with this threshold, we can classify the patients as having high risk of amplification, of acquiring this oncogene amplification, or low risk of acquiring amplification. And that is actually the output of this framework. So we developed this forecasting framework, and then the next step is to assess the performance, if actually it works or not. So for that, we used longitudinally collected tumor pairs, and what we did was to apply the framework, this forecasting framework, in the primary sample of a patient. We classify then these patients as high risk or low risk, and then we observe if that oncogene amplification is actually seen in the relapse or the metastasis from the same patient. And for that, we use two different scenarios. One, we anticipated the amplification of ER in prostate cancer samples. And for that, we combine 3 different prostate cancer cohorts. And we also forecast the amplification on EAST1-H3B in non-small cell lung cancer, because that's a gene that is normally amplified in metastasis. And for that, we use the TracerX score. And actually, what our results show is that we are able to identify the patients that are going to acquire those amplifications, those oncogene amplifications, with a high sensitivity and specificity. So we validated the performance of these forecasting framework. And then the last step was to test the clinical utility of this framework, because that's the main goal of our lab, to move our technology to the clinical setting. And for that, we used 2 different clinical scenarios. The first use case was to forecast the prognosis in low-grade gliomas via CDK4 amplification. And the second use case was to forecast resistant to EGFR inhibitors in non-small cell lung cancer via MET amplification. And today, I'm just going to focus on present the results of the second use case. So we were interested in predicting the resistance to EGFR inhibitors. because this is a treatment that is normally used as a first line for non-small cell lung cancers that have EGFR mutations. And these patients normally they respond quite well at the beginning, but most of them develop resistance. And here in this figure, you can see all the different mechanisms that actually are causing or are leading to the resistance to EGFR inhibitors. And one of the canonical resistant mechanisms is MET amplification. And this is quite important as a first-line resistant mechanism because this occurs in 50 to 30% of all non-small cell lung cancers. So our aim was to see if in a way we can anticipate MET amplification for selecting patients that will benefit from a new therapy that is amivantamab that actually is inhibiting both EGFR and MET at the same time. So if we can, in a way, select those patients that are going to benefit from this upfront dual inhibition. And this is particularly interesting because this treatment is quite toxic. So we need a really good biomarker for selecting those patients that are actually going to be to benefit from this treatment. So for that, we started with an in vitro experiment. So we collected non-small cell lung cancer cell lines, 4 different non-small cell lung cancer cell lines that have EGFR mutated. And what we did was to treat them for a long period of time with EGFR inhibitor to derive resistant clones. And the first thing was to apply our forecasting framework to the parental cell lines to classify them as resistant or sensitive to EGFR inhibitors via MET amplification. So we classified them as high risk or low risk of acquiring MET amplification as resistant mechanism. And actually, one of these cell lines was classified as high risk, and we used for that an optimal threshold that we trained in an independent cohort. And only the interesting point is that only these cell line that was classified as high risk was actually the one that we observed MET amplified in the resistant clones. So we don't see a MET amplification in the cell lines that were classified as low risk, but we see in 11 of those 12 clones derived from this high risk cell line that we observe this MET amplification. So okay, we can in a way demonstrate that we can detect those cells that are going to acquire MET amplification as a resistant mechanism. And then the next step was to test our hypothesis. Can we, in a way, avoid the amplification, the MET amplification, by treating with both inhibitors, with EGFR and MET inhibitors at the same time? So this was our next experiment. We take these high-risk cell line, we treat them with EGFR inhibitor or with the combo of EGFR inhibitor plus MET inhibitor during 30 days. So after these 30 days of treatment, we perform single-cell linear sequencing of the resistant cells, of the cells that were in the plate. And what we observe is that for those cells that we treated with both with EGFR inhibitor and MET inhibitor, we could avoid the amplification of MET as a resistant mechanism. However, we see a really high increase in the number of copies of MET in those cultures that were only treated with EGFR inhibitor. And actually, those cells that are treated with both have a similar number of copies that the parental cell line, that the one that we observed in the parental cell line. So that was super cool, but everything is done in vitro. So then the next step was to move to a patient cohort. So we have a collaborator from the Hospital of Octubre that have a cohort of non-small cell lung cancers that are treated with osimertinib, and they have a follow-up of around 5 years for those patients. And the limitation here is that we don't have the biopsy of the relapse for those patients, so we don't really can detect the amplification, if the amplification has been acquired in the relapse or not. But what we used as a proxy was the progression-free survival and the overall survival for those patients. So what we did was to compare the progression-free survival and the overall survival for patients that were classified as a high risk of acquiring metamplification and those that were predicted as low risk of acquiring this metamplification as a resistant mechanism. So here is a biomarker of progression-free survival or overall survival. And actually, the point is that those differences in survival times were independent to other covariates that are normally linked to outcomes towards outcomes for those patients. So just like a sum up, this third part of my talk, the last part of the talk, actually, I show you that using the mutational processes that drive chromosomal instability, together with the topological constraints and the fitness effect caused by the acquisition of oncogenes in a specific tumor type, can be used to predict the acquisition of oncogene amplifications, and actually that this forecasting framework can enable earlier therapeutic interventions. So just to sum up my lecture, today I have explained you how we can infer the mutational processes driving chromosomal instability, and how we can use these signatures to understand the theology behind those complex tumors. Actually, I also explained you how we can use these mechanistic insights, these signatures, to predict treatment response. And in particular, I showed you that we can use those for predicting response to 3 different cytotoxic chemotherapies. And in the last part of my talk, I explained you how we can use these mechanistic insights also to forecast tumor evolution, and in particular to forecast oncogene amplifications. And now in the lab, what we are working on is to adapt or to move this technology of signatures of chromosomal instability at single cell resolution. So just to finish my talk, I would like to thank my group, led by Jeff McIntyre here at the CIN, all the people that have been involved in the different projects that I have presented today, our collaborators, funders, and of course, thank you for taking me attention. And now I'm more than happy to answer any questions.
Thank you, Barbara. That was a fantastic talk. We have a few minutes for questions. Please, attendees, just type your questions in the Q&A basic box, or using the functionality from Zoom. I have already a number of questions, so we'll try to go through some of them at least. The first question is about related to the last part. So could you please comment on the biological link between the features in the forecasting algorithm and the amplification of, for example, MET?
Okay, so first of all, what we did was to analyze or to learn from the different cohorts that the TCGA, the P4, and the Harwick, what is the features, the copy number footprints that are explaining these oncogene amplifications in the different tumor types. So we did that for each different tumor type independently. And what we explored was the segment size that these oncogene patients have in that region, also the copy numbers that they gain, and then we modify a little bit our feature encoding that was used in the previous part of my talk, because there are three features that were explaining the clustering events that are in a specific region, but we had to modify a little bit that definition to be able to map each signature in a specific copy number segment. So we did really work we explored a lot what are the best features that are explaining if those oncogenes are clustered together or not in a specific region.
Okay, thank you, Barbara. One question from George, who says, great talk. And when you calculate your risk score, does the selection coefficient depend on treatment context? For example, androgen receptor amplification in prostate cancer is usually only selected for when androgen deprivation therapy is used.
Yeah, that's a really big question, like a really good question, because we were working a lot around that, because all the selection pressures depends on the clinical context. In fact, we learned that trying to integrate as much data as possible to take into account all these different variations of the selection pressures according to the treatment, any like all the possibilities that can evolve in the oncology applications. For that reason, we have samples that are treated, samples that are not, and all of that. But the key point is the optimal threshold. So in this part of binary-ization, this optimal threshold needs to be trained in a reference cohort that is actually similar or as similar as possible of your clinical context. And for example, in the case of the example that I show about ER amplification, what we did was to have a reference cohort that was treated the same way that the patients that we were using for forecasting for this specific use case or performance task.
Okay, thanks, Barbara. So there is one question about intratumor heterogeneity of copy number profiles. So the question is, have you found whether tumor cells are heterogeneous in terms of the type of copy number aberrations within the same tumor? And if so, would targeted treatment potentially just drive tumor evolution to select for the cells with the copy number with types of copy number aberrations that the treatment is ineffective against?
Yeah, I mean, that's the reason basically that we are trying to move all our technology to the single cell SMR, because that will allow us to dissect which is the mutational processes that are active and is driving the acquisition of more alterations, so the evolution of these tumors. And we are trying to use biomarkers that are getting these patterns or these genomic spares that are linked to the process that is active. But it is true that intratumoral heterogeneity is a really big challenge in tumor treatment. And the good thing of our signatures, in a way, is that we can quantify the activity of those signatures in a tumor. And that is a readout about what is the size, in a way, of the clone, or how size of the clone that is this process active. So that, in a way, can give us an idea. We can order the different drugs that we can use for tackling those complex tumors. But of course, I think that all of the CIN community is working in intratumor heterogeneity and in trying to dissect those processes that are ongoing in a tumor.
Perfect. Thanks so much, Barbara. So I'm mindful of time. We've reached the end of the hour. So thank you very much, Barbara, once again for your fabulous talk. Just a reminder to everyone that we will be uploading the talk to the YouTube channel of the seminar series, and we will make that available there in a few days. So I wish I wish all of you a wonderful weekend, and see you in the next seminar, which will be in a few months. Thank you very much, and thanks so much, Barbara, for this amazing talk. Thank you.
Thank you for the invitation.